Welcome to Med Noobs. Today we're discussing complications of diabetes mellitus. So let's start with some etiologies of DM. So some causes of DM include you're going to have, in type 1, you're going to have immune-mediated destruction of your beta cells. So you're going to see insulin deficiency, complete insulin deficiency here. It could be idiopathic as well. In type 2, you may have a variable number of beta cells, but the key thing here that's causing the diabetes is the resistance. So you have insulin resistance here, and with some degree of insulin deficiency as well. You have gestational diabetes, can cause DM also later on within the child. That's going to have if you're a child born to a mother with diabetes will have a high birth weight, have cardiac issues. You're going to see a slew of problems, but then also the child themselves will develop, or can most likely to develop, diabetes as well. So you have some genetic components here with the beta cell. That's something to keep in mind. I don't want to get into the specific mutations that cause this too much, but you can look up what's called the MODY, so MODY, that's maturity onset diabetes of the young, and there's various mutations here that result in this defect of beta cell functions, including mitochondrial DNA mutations or glucokinase mutations, hepatocyte mutations as well. So just to keep that in mind, that's also a component here that can result in DM. Then you have defects in insulin and insulin production. So if you have a defect in pro-insulin conversion, or your receptor isn't working, if you have a mutation in your insulin receptor, you're going to have diabetes mellitus as well. Or if you have a gene mutation that's causing an insulin defect, that's going to cause diabetes as well. And then you have other syndromes that are associated with diabetes. You have a few here to keep in mind that might be more high yield. Definitely Down syndrome is very high yield, so you're going to see diabetes in Down syndrome. You're going to have it in Klinefelter syndrome. You see it in Turner syndrome. So those are a few genetic associations that you see here that cause diabetes mellitus, or are associated with diabetes mellitus as well. Next, you have exocrine pancreas defects. So if you think about it, well, what are some things that could go wrong with your pancreas that can lead to DM? Well, you have chronic pancreatitis, right? So that can cause problems with your pancreas that can result in DM. If you have surgery and you remove your pancreas, obviously that's going to result in diabetes. If you have cancer or some sort of neoplasia, you can have cystic fibrosis, can cause issues. Hematochromatosis as well can cause issues there also. If you have fibrous calcifications of the pancreas, then that's going to result in a non-functioning pancreas and result in diabetes mellitus as well. So next you have pathologies of the pancreas. So if you think about it in a different way now, if you have problems with your hormones, what are some diseases and pathologies there? Well, remember you have in endocrinology, you see also acromegaly, you see Cushing syndrome, hyperthyroidism, pheochromocytomas, and gluconomas as well. So you have your neoplasias, your cancers, your hormone pathologies as well can cause diabetes mellitus. And then you have a couple infections to keep in mind. So it may not be as intuitive as the other things that you can logically kind of make sense of, but keep in mind cytomegalovirus and Coxsackie B virus can cause diabetes mellitus as well. And then moving on to drugs. So we talked about hormone defects. So what are some drugs that can cause the same type of issue that can cause a pathology? So you have glucocorticoid use. If you have uh, thyroid hormones, alpha interferon, protease inhibitors can cause problems here also. Beta adrenergic agonists, thiazides, nicotinic acid, phenytoin, of course, which is a terrible drug that causes all kinds of side effects. So those are some drugs that can cause diabetes mellitus as well. So some risk factors involved in diabetes. So generally, most people are going to be familiar with, family history, obesity, smoking, hypertension. You can have insulin resistance, like we discussed. Lack of exercise, other lifestyle issues as well are going to contribute to diabetes. But then you have diabetes-specific issues. You have glycosylation of your proteins in your hemoglobin. You see that in if you have hyperglycemia, you're going to have that happen. That's going to cause issues that can lead to other comorbidities. Same thing with hyperinsulinemia. And you have comorbidities here, and their mortality is especially high in DM when it's associated with cardiovascular disease or cerebrovascular disease. And often complications of diabetes mellitus result in these two things as well. So it can be difficult to treat these patients in later stages because the one causes the other often, unfortunately. So let's move on to complications of diabetes in the vasculature. In the macrovasculature, you're going to see this in type 2 diabetes. So you have comorbidities, as we just discussed, and you see cardiovascular disease, you're going to see your coronary issues, you're going to see atherosclerosis, you're going to see MIs, cerebrovascular disease, you're going to see types of stroke, peripheral vasculars, you're going to have issues with your extremities as well. So you have your macrovascular complications in DM2. You have a greater impact on the mortality in DM2 as well. So like we were talking about comorbidities in the slide before, again, keeping that in mind, your mortality is impacted here in DM2. Your microvascular complications, you see it in both, right? So because you have glycosylation onto your proteins, and hemoglobin is a protein, and so hemoglobin's on the RBC, and your RBCs are trying to deliver nutrients to your tissues, and at the microvasculature, you're gonna have a decreased amount of nutrients delivered because the vessels are so small. You're not gonna have enough RBCs to deliver, and if the RBCs are not functioning properly, you're not going to have the nutrients there. If you're not going to have the nutrients there, then your issues like the small vessels in your eye are going to be affected. You see retinopathy. You see the small vessels in your kidneys are going to be affected. You see nephropathy. You have small vessels in your end extremities are going to be, and your capillaries are going to be affected. So you see neuropathy in your fingertips and your toes. So let's talk about key pathologies here for a second. So in the pancreas, you can have a variety of range of things going on patient to patient regarding the beta cells or the islet cells, as far as how much lymphocytic infiltrate is involved, what the number of cells left is the patient newly symptomatic, is the patient been is it a result, or the current symptoms a result from something more long-standing? So just a couple things to keep in mind in the pathology of the pancreas. You have something called insulitis, which is that heavy lymphocytic infiltrate around or within the islet cells, and that you usually see in a newly symptomatic type 1 diabetic patient. Then you have amyloid deposition, and that you see in long-standing type 2 diabetic patient. So that's a couple key pathologies to keep in mind for the pancreas. Another key pathology associated with macrovascular disease is hyaline arteriosclerosis. So this is also associated with hypertension, and you'll see this more in severe diabetics. So it's a macrovascular complication, so that means you're going to see it in large vessels, the aorta, or medium-sized arteries. This is going to be one reason that you see MIs, cerebral strokes, aortic aneurysms. You can have this contribute to gangrene in the lower extremities as well. Another key feature to know is diffuse thickening of the basement membrane. And you see this is more of a microangiopathy. And you see this in many different types of tissue. You see it in the capillaries. So you have the thickening, diffuse thickening of the basement membrane in the capillaries, skeletal muscle, renal glomeruli, and the medulla, in the skin as well. It can affect even some non-vascular structures, renal tubules, Bowman capsule, peripheral nerves, placenta. So definitely a key feature to keep in mind, that you see all this in diffuse thickening of the basement membrane. You know, it's one of the main causes for the development of the nephropathy, retinopathy, different forms of neuropathy also. So two clinical features, or features you might see on boards, especially that might be more high yield associated with complications of diabetes, are the hyaline arteriosclerosis and the diffuse thickening of the basement membrane. And we discussed already a little bit about non-enzymatic glycolization. So essentially, again, it's when glucose attaches to different amino groups, different proteins. We focus on hemoglobin especially. You know, that's one of the main reasons we do the hemoglobin A1C test. You know, that's what we're trying to determine, how glycolysized the hemoglobin is, to try to determine you know, the patient's progress with the disease. And then we have activation of protein kinase C. So what did protein kinase C do? Well, recall that the activation of protein kinase C is involved in the signal transduction pathway for many different systems. So what are some of these effects that it's involved in? Well, the activation of protein kinase C can increase the deposition in basement membrane material. It can be responsible for the neovascularization that you see in diabetic retinopathy because of the proangiogenic molecule vascular and endothelial growth factor as well. Also, the activation of protein kinase C can lead to reduced fibrinolysis, which can cause possible vascular occlusive episodes as well. So that's something to keep in mind that may not be as intuitive, but protein kinase C activation can be involved in these pathologies. So what are some metabolic complications of diabetes? Well, in DKA, you see that it's type 1 involvement, and it's also involves some severe insulin deficiency, and then glucagon is increased as well. And then since you're trying to get energy, your body's going to go and break down fatty acids for ketones. So you're going to see an increased amount of ketone release from free fatty acids. That's where your body gets ketones from. So you're going to have your the breakdown of fatty acids in your adipocytes. You're going to have ketones. Now, the thing to know here is that DKA can be life-threatening, especially when the patient's dehydrated. And the difference is in type 2, you have non-ketotic hyperosmolar coma. You also see dehydration here, but it's because you have a hyperglycemic diuresis and no water intake in type 2. That's going to result in the severe dehydration. Whereas in DKA, you see that dehydration is something that can make it worse. But it's because of your insulin deficiency, increased glucagon, and free fatty acid in DKA in type 1. So that's a difference in metabolic complications to keep in mind between type 1 and type 2. Moving on to cardiovascular disease, we touched on a little bit already. Complications you see in cardiovascular disease are going to result in a various amount of things that can cause and increase your mortality here. So coronary artery disease, you have cardiomyopathy even of the small vessels in DM. And then you can have sudden death, you can have an MI as well. Keep in mind you have an increase of atherosclerosis in diabetes also. So you have various cardiovascular complications. Similarly, you have cerebrovascular diseases. You have your vessels are involved again, but now you're talking about vessels in a different area. So obviously that's going to cause different issues here. So again, the mortality rate is going to increase when there's hypertension plus DM. You're going to have problems repairing your blood vessels. If they become narrow and stiff, you're either going to have problems delivering nutrients to the tissues. You have ischemia involved. You're going to have either a stroke or hemorrhagic stroke. So cerebrovascular disease is a sometimes fatal complication when you have hypertension plus diabetes mellitus involved. And then you have peripheral vascular disease. You have claudications. What are claudications again? It's painful limping. You're going to have problems and deficits in sensory and motor. You're going to have sensory and motor issues. So you see pain, weakness, cramping as you're trying to walk. You have poor blood flow. The patient will try to walk and you'll see painful limping, and that's claudications. So if they're not able to feel in their extremities, if they have a wound, it can develop, gangrene can develop. So that's why foot care is so important, and it's one of the major causes of ischemia of the foot. And you want to be able to treat the patient and have good foot care and catch this early on so you can prevent amputation. Moving on to retinopathy, up to 80% of patients. It's more between 60 to 80% of patients who've had diabetes for more than 10 years, 10 or 15 years even, develop retinopathy. So it's a leading cause of blindness in the US for middle-aged Americans. Around the world, it's about 2.4 million people are affected and blind because of this. And again, laser surgery and new treatments can slow the progression of the disease, but of course managing the blood glucose levels early on is the best, and we always want to try to prevent. And this is an example of what it can look like, where you have more of a normal vision on the left, and you have what it can look like with retinopathy on the right. And with retinopathy, we talked about the neovascularization that can occur, and you can see the little hemorrhages on the left over here, and what you have as quote cotton wool spots as well. So just a good image here to try to visualize better. So moving on, let's talk about some nephropathy before we finish up here. So you have Kimmel-Still-Wilson disease. So that's a type of nodular glomerulosclerosis that's associated with diabetic glomerulosclerosis. which you can see proteinuria because you have your glomeruli not functioning properly. So the Kimmel-Steele-Wilson, you see an issue with the glomeruli as compared to normal. You see the pink nodules in here as well. Again, this can also be called nodular glomerulosclerosis. You can see hyalinization of the glomeruli as well. You can also see some pyelonephritis, so some infection-related issues as well, with some papillary necrosis in this. So just another side note. And then of course, if your glomeruli are not functioning properly, you're gonna see proteinuria. Fortunately, tubules are usually spared here, and that's if your glomeruli are not working, and you're going into kidney failure. Well, this is one of the reasons why you have that, and then this is the main reason for dialysis. So you want to treat it or try to treat it with ACE inhibitors or ARBs, even if you catch it early on or you see progression of it early on. And let's take a look briefly what it looks like. So on the left you have a normal glomeruli, and on the right you can see the Kimmel-Steele-Wilson nodules here, the large pink areas as well. So you see the difference between the normal glomeruli and the one you see in this diabetic glomerulosclerosis, or nodular glomerulosclerosis, or Kimmel-Steele-Wilson disease. It has a few different names, but here you can see the visual. So some signs and symptoms. You can see frothy urine. You see edema. The weight gain could be there unintentionally, or anorexia could go either way. You have some general symptoms: nausea, vomiting, malaise, fatigue, headache. But definitely you want to pay attention to the key features here to try to diagnose or have an idea of does this patient have nephropathy. So onset of uremia. Is there blood glucose control out of whack? Is it stable? Some things to think about. Are they decreasing their insulin requirements? Is their glycemic index through the roof? What's going on with the patient? Well, in nephropathy, you see renal failure, like I said earlier, and it's about 25% of the patients result in renal failure. So again, early on treatment and prevention is important. And over here is a good example of proteinuria and what's going on in the glomeruli when it's failing in diabetic glomerulosclerosis. So on the lower right, you see the healthy glomeruli and urine flowing through, and then you have the picture next to it, proteins leaking out, the glomeruli isn't functioning properly, and you have proteinuria. So that's how it can affect the glomeruli in diabetes. And some complications of neuropathy. So we've talked about loss of pain and temperature. Some small fiber neuropathy affects the small fibers with you have pain and paresthesia in lower extremities. Your pain and temperature loss. Autonomic dysfunction is prevalent. Large fibers, you have sensory ataxia, vibration, position, sensory loss. A way to can be a diagnostic tool is test the ankle reflexes as well, because that'll be at a loss. And with neuropathy, you see it 20% is prevalent in diabetes. You're going to have mixed type, so sensory or motor loss, or both. Treatment is not the best. Unfortunately, patients usually progress and the progression worsens. So you want to try to optimize glucose control. You could use simple analgesics, TCAs. Then you get into drugs like phenytoin or carbamazepine after that. Again, phenytoin has a lot of side effects and is not always the best drug to use, but this is something to keep in mind. Of course, foot care is essential, as we discussed before. You want to prevent any amputation, gangrene, some wound that the patient may have there that they don't even know that they have. So foot care is very important in neuropathy. This is a pinprick test. We can see the points when you're doing an exam on a patient to test their sensory loss in diabetic neuropathy. So these are some of the points that you can do and ask the patient if they feel the filament that we use. And that concludes our lecture on complications of diabetes mellitus. Remember to be confident in your learning and always trust your brain. Thank you.